So good afternoon. I'm Dr. Emily Slopnick. I'm one of our urology staff here with a team of experts on pelvic pain. I myself specialize in pelvic floor issues and pelvic floor reconstruction, along with my partner, Dr. Lee Wong Roberts, who we'll hear from. We also have a couple of wonderful members, Cameron Pikula from our pelvic floor physical therapy team, which is essential to almost all of our treatment plans, and Melanie Simons from our mental health team. So we're very excited to give you our perspective and a little bit of background and education on pelvic pain. This is kind of an introduction, and we hope that at least this can help you and your friends or loved ones get connected with someone from our pelvic pain team. So I'm going to hand it over to Dr. Wong Roberts to start our discussion. Please enter any questions you have in the chat. If there's something quick, I'm going to go ahead and interrupt our panelists and answer that. Otherwise, we will absolutely get to your questions at the end of our presentation.
Great. Thank you so much, Dr. Slopnick. I appreciate that. Hello, everyone. Good evening. Thank you for joining us. My name is Dr. Lee Wong Roberts, and I'm, as Dr. Slopnick mentioned, I'm one of the associate staff in also female reconstructive surgery. And one of the things that we both treat is pelvic pain. And so I want to start off the webinar just by explaining kind of basic pelvic pain. What is it? What are the possible causes? And is specifically one cause and how we can treat that. So looking at pelvic pain, thank you, Emily. It's the idea that you can have pain in the pelvic region. And what we define that as is anywhere along the lower abdominal areas. So kind of like the bikini line area, we call it the suprapubic area. It can also be in the genitalia, so the vagina, the scrotum, the penis, going back towards the rectum sometimes, and sometimes the pain can also be in the lower back, so kind of going around the back. It can be in both men and women, and this is very important. This is a female imaging, but it can be both in men and women. And you can have other associated symptoms, such as urinary symptoms, bowel symptoms, gynecological symptoms, pain with sex, during penetration for females or for men during ejaculation. And so any of these kind of symptoms you may have. Next, please. Now, there are various causes because in the pelvic region, as we can see, there's a lot of different organs. So sometimes it could be very specific organs such as the bladder, and we call that interstitial cystitis. It could be the reproductive organs, endometriosis, causing issues with the uterus, or sometimes the prostate. The prostate can be inflamed for men. It could be the bowel in that area, so irritable bowel syndrome. Sometimes you can have a specific nerve called the pudendal nerve that's the cause. And if it's injured, we do workup to see if that's the case. It could be the pudendal nerve. And most commonly, it could be absolutely the pelvic floor muscle. Next, please. Today, we're going to go ahead and focus on specifically the pelvic floor muscle, mainly because the pelvic floor, it could be one of the most common causes, but it can also be an innocent bystander that's a secondary cause, meaning that you can have prostatitis, you can have endometriosis, and this be another cause of pain. So you got to really treat this. So just to kind of briefly overview the pelvic muscles and everything like that, as we see here for the men and for the women, you got a lot of different causes that can be the issue, as we mentioned already. Each one, the important part of this is that because there's so many different causes, it's important to talk to your physician to really identify the appropriate one, and so you can get the appropriate treatment. And we kind of go from there. Sometimes it can be from next slide, please. Some causes can be prior infection, right? So you can have a true UTI, urinary tract infection. You can have a true prostatitis. You can have a vaginal infection, right? And I say true because sometimes you can, if you have these symptoms, but a negative if a workup is negative, sometimes it's not an infection. So you got to be, there's nuances to it, right? So you got to be careful, but sometimes it is an infection that can cause this initially. It could be prior surgeries, either in the pelvic region or otherwise. It could be chronic conditions such as endometriosis, fibromyalgia, all of those different things. And then it could be plain old stress that can be causing the pelvic floor to tighten and cause pain. So the way that we do it is that the way that we treat it is we treat it in a multidisciplinary team approach. So as Dr. Slopnik and I, we're urologists, but we also work collaboratively with our patient or our colleagues in pain management and gynecology. And of course, you're going to hear from Cameron Pikula, our physical therapist, who's amazing, who we work closely with. And then, of course, the body and the mind's connected. And so, meaning that if you are in pain, you might tighten those muscles and cause more pain. Similarly, if you are, in pain, your mental health can be affected. So, Dr. Simons is going to be speaking with us about that. And then lastly, one thing I do want to just mention on this one is that, because the pelvic area is important for relations and everything like that, your sexual relationship with your partner is it could be impacted. I've had partners who feel very guilty because they feel like they're the cause of the pain, which is the furthest thing from the truth, right? This is a physical condition that can both affect the patient and the partners. And so it's important a lot of times for both people to have a good communication and use, and even talk to sexual counselors, because your partner can absolutely be a healing part to the process, right? So, and Cameron will speak to us in a little bit of how that can work. But next, please. So the treatment plan that we use often, first line absolutely, is pelvic floor physical therapy. And the way you want to think about it is this, meaning that when you think about the muscles in the pelvic area being tight, you want to relax it, right? Just like if your muscles in the shoulders are tight, you want to be able to relax it and work on it. So pelvic floor physical therapy is very important. Now, this is a study just showing that if you were to target the muscles themselves, the pelvic floor muscles themselves, it's better than just getting an overall body massage. So it means that it works, right? So number one, pelvic floor physical therapy. Next, please. Number two, now, if your muscles are tight, you can absolutely take, a muscle relaxant, something like baclofen or Valium, right? But if you take it by mouth, that's going to go everywhere, and we don't need it to go everywhere. We want it targeted in the muscles themselves. And so sometimes using it in the vagina or inserting into the rectum, where the muscles are easily accessible anatomically, that can really help distribute the medication right into those muscles and relax it. So sometimes people find that is very important as a supplement, not you use it in conjunction. You don't replace, but you use it in conjunction. Okay. Now, thirdly, you can do something called trigger point injections, which are procedures that your physician, so Dr. Slopnik and I, we do this often, where if we were to palpate or push on those muscles, this is a image for the female, but you can imagine analogously for men through the rectum. If we were to press on it, on those muscles around those area, and you have pain, and we inject it with a numbing med and a steroid, there could be immediate relief with the numbing meds. The steroid kicks in a little bit later, but it can decrease the pain gradually. Now, the important thing about trigger point is that it can give immediate relief, but it is temporary. So this is not something that is, a one and done deal and that's all you need, right? So we can't guarantee that. But it's a combination of all of these treatments, right? Consistent combination of all these treatments that you can really get good relief with a gradual decrease in pain. Next, please. And then lastly, based on some of our data, especially those in Europe, that shows that this is part of their guidelines of neuromodulation, which is the idea that you can, if you change the way that the pain signals from the nerves work and interrupt that pain signal, you can decrease pain. And so neuromodulation is a procedure, again, that your surgeon would do, that you can place for that's been done for pain in other areas by pain management, but for specifically pelvic pain, the nerves that are targeted is the third sacral nerve root or the pudendal nerve. And so if you have any questions with this, we won't go into too much detail about this procedure, but speak to your surgeon about this. Okay. All right. Next, please. So just a brief key takeaways, pelvic pain can be caused by a variety of sources, a lot of different organs, and that can manifest itself in a lot of different symptoms. And you can have a spectrum. Some people it's just a mild nuisance. Sometimes it's debilitating, right? But just know that, speak to your physician about this and they can help figure out what's going on. Secondly, you are not alone. We are here to help you with a large multidisciplinary team. And I know in the midst of all the pain and stress, and some people have been battling this for years, it seems hopeless, right? Well, we're here to say that there is hope, and it's not going to be easy. It's not going to be immediate. It's going to be gradual, consistent work, but we're here to help you. So please reach out if you have any questions, and we'll answer any questions later on. Next slide.
All right. Thank you, Dr. Wong-Roberts, for leading us in. Can you guys hear me okay? Okay. My name is Cameron Pikula. I am a pelvic floor specialist with Cleveland Clinic, now at the CCAC Beechwood location. And so I want to talk a little bit about what is pelvic floor physical therapy. Most people have heard about physical therapy, but very commonly, most people are not familiar with this. And I'll get into a little bit more detail about that. Next slide. Okay, so like Dr. Wong-Roberts just very well went over this, that we definitely work in a true multidisciplinary team and address a lot of symptoms in a multidisciplinary approach. Next slide. So a little background, like what is the pelvic floor? So we know that it has, 5 major functions. It has to be able to help support our organs. It's sphincteric, so it has a role in bowel and bladder function. It definitely has a role with sexual function as far as arousal and orgasm goes. It stabilizes. It's a main stability for our hips and our back and our belly, and it helps be able to transfer pressure from the ground as we're walking up into the pelvis and into the torso. And then it's a sump pump. So it has this role with the lymphatic system and being able to get blood flow back up to the heart and processed through the body. Next slide. So a little, pelvic girdle anatomy. There is the bony anatomy of your spine and your hips, and then your pelvis. You've got a lot of ligaments that are around that area as well. And then mainly the reason, part of what we're talking about today is the muscle system. So you have a muscle system all around the pelvis, and then you have this huge intricate system in the pelvic floor. In female anatomy, there are over 20 muscles. They live in multiple layers. So part of our job is to figure out exactly where is the pain coming from. Today we're talking and focusing more on sexual function. In the male pelvis, there are really 2 separations or delineation in musculature, but trying to figure out as physical therapists, where is the pain coming from? Because it helps us be able to derive a treatment to be able to help get symptoms better and help less pain with intercourse. Next slide. So there are multiple different things that can present with sexual function and difficulty with intercourse. In the male pelvis, it may be pain with erections or ejaculation. In the female pelvis, it may be, pain with penetration. And we kind of decipher that out to whether it's pain at the opening or pain deeper inside. Sometimes it can be both. And it gives us an idea of where is the pain coming from through questioning and asking, does that happen only during? Does this last afterwards? In the female pelvis, is there pain placing tampons, pain with inner or intravaginal exams or speculum exams at the physician or gynecological or urology office? And then there's another kind of term disorder called persistent genital arousal disorder, which can be an uncomfortable sensation that can happen either in the male or female pelvis that can be very distressing, but also has a role within the sexual function or dysfunction side of things. Next slide. So what is pelvic floor physical therapy? So I can talk to our team that all of us, we're now a team of about over 50 providers within the Cleveland Clinic enterprise wide, and we've all done specialized training after physical therapy to really have this niche of treating pain in bowel, bladder, and sexual function. So what happens when you show up for a evaluation? Maybe the provider made this recommendation. They're like, I want you to go to pelvic floor physical therapy, and you get here and you're like, I have no idea what this is. I maybe got on Google or I got online and I'm really nervous. So the first thing we do is spend a lot of time talking and figuring out where are the problems, where's the difficulty, where's the pain coming from? Do you have pain or symptoms and other things? Are there other medical conditions that you maybe have been diagnosed with that can contribute to symptoms happening in the pelvis? And then looking at an objective exam. So there's this big laundry list, and sometimes we don't get to everything the first visit. But part of it is figure out, what's the driver? Where are these symptoms coming from? We know there can be overlay coming from kind of the medical system of maybe it is organ-based, but because of the irritation happening in the organ system, that it's causing this irritation and overflow into the muscle system as well. And that's where that multidisciplinary approach really makes a big difference. And we've talked about stress impacting, which we know Dr. Simons will get back to more in that mind-body piece. I know I get a lot of question coming in first of what's going to happen, and is there an internal assessment? And maybe especially for someone who's had a lot of pain, that can be really scary and discouraging initially. I think absolutely we're doing where comfort level is. We are absolutely trained to do intravaginal and or intrarectal muscular assessments, looking at what is the muscle tightness, tension, can we reproduce familiar pain? These muscles are like any other muscles in our body, but they live in the pelvis. And so it's a hard and challenging to get to them without assessing internally. However, a patient isn't comfortable or isn't able, or for a various reason, is not okay with that. That's not something we include in our treatment or assessment. And it may be if there's a history of trauma, that sometimes it's working with a counselor or psychologist and kind of bridging that process until you are ready. And that's absolutely okay. I would say I have a large majority of patients that have had some type of trauma that definitely lead into some of their symptoms. And that's where a dual approach of treating multidisciplinary can make a big difference. Next slide. Okay, so what is the goal of pelvic floor physical therapy? It's to help retrain the musculature to relax, to optimize function. So both in the male and female pelvis, they have to open and relax. In the female pelvis, they have to open and relax for something to insert, whether that be digital penetration, whether it would be penile penetration, some type of toy or something like that. In the male, we need it to relax to be able to allow for blood flow for erections and ejaculation. Next slide. So treatment options, I already led into some of this, but there's a multitude of different options for treatment. And I'll get into a little more in the next slide of how do we get partners involved. I think it's definitely depending on partner in this situation, a lot of, like Dr. Wong Roberts, discussed, that a lot of partners want to be involved and they don't like the fact that it's hurting their partner. And so that can affect from a relationship standpoint. But working on a holistic, multi approach of looking at hip stretching and exercises that you can do at home to help relax and open the muscles so they have better flexibility, so they're not as tight when penetration occurs or when blood flow occurs, to allow for, erections and things like that. And then the best, I tell my patients, I love seeing them, but I'd much rather be able to give them the tools to be able to manage these symptoms on their own. And then we do that kind of by a multitude of different ways. If you go to the next slide, it has a great understanding of how do we do this. So because we said that the muscles live on the inside of the pelvis, there are different tools and strategies to be able to work on the musculature to help retrain them to relax and open. Sometimes that is having a partner attend a session and teach partner how to be able to work on the muscles, and different techniques to be able to do, prior to starting penetration, to help penetration be more comfortable. Sometimes the second one is using a wand, and we recommend different items for different reasons. The wand is better at being able, I explain it as like an extension of my finger, to work on some of the muscles that are deeper in the pelvis and help and relax. And that's something I have patients purchase and bring in and go over absolutely how to be able to use that. And the goal being, eventually you don't need it, but it can be something to work on help relaxing the muscles, but then also using prior to penetration to help penetration be less uncomfortable. Or less pain with erections or ejaculation. And then the dilators are primarily used in female pelvises, but to help slowly relax and open the muscles. And then it's a progressive size. So you work slowly up those sizes with guidance and I always tell patients there are multiple, sets and sizes, and figuring out what works best, but they can be a very good option to do as well, and to help make penetration more comfortable. Next slide. Okay, so I put a piece of information in. I think absolutely the first piece is talking to a medical provider. Like Dr. Wong Roberts said, making sure that we're addressing the medical reasons why things can happen. The cool thing about Ohio is we also function as a direct access state, meaning that you can refer yourself to physical therapy without having to have a physician's referral. And very commonly I see patients on a direct access standpoint, and I'm referring to a provider to make sure that we're not missing something, or if there's another medical piece going on. And I included the number, the general appointment number. The nice thing about that, I mentioned there's 50 of us. I think we're actually at 53 now, but how to find the most convenient location as far as date, times, who does what. The call center, which is that number, has the best house of that information, because our team is forever changing. But that can be a good information of how to find us and where we exist. All right, next slide. Thank you.
Thank you so much, Cameron. And we will, I believe, go over how to reach everyone and make appointments. And this presentation will also be emailed to all of you, so you will have access to this in case you didn't get the number down at this point.
Okay. So my name is Dr. Madison Simons. I'm actually a GI psychologist, so I specialize in treating motility-related GI conditions, but have a relationship with our gynecologic and urologic teams here in treating patients who experience chronic pelvic pain. And so what I want to talk about today is how pelvic pain comes and impacts other aspects of your quality of life. And if you don't mind moving it to the next slide for me. We're going to start with what we consider cognitive affective factors involved in pain perception and response. And so though pain is experienced in a certain part of your body, whether this is the pelvis or another area of the body, it's ultimately the brain's responsibility of how it perceives and then responds to that pain stimulus. And so there are factors that influence the experience of pain. One of those that we talk about frequently in the GI setting or in the pelvis is something called visceral sensitivity. And this is usually driven by some type of injury or damage to the nerve linings in that area of the body. And the effect of this is that normal sensations can be perceived as painful. and what this experience would be like. As you might imagine, if you had burned your arm on the stove, normally your shirt wouldn't be painful to you at all. But if you had burned your arm on the stove, any material you wore, including your softest sweatshirt, could feel excruciating to you. And the same effect can take place in the GI tract or in the pelvis. Go ahead and move it to the next slide. When we have visceral sensitivity or a condition that changes the nerve linings in one of the areas in the abdominal pelvic region, this can start to affect the other organs surrounding that, because there's a shared nervous system between the bladder, the bowel, and the reproductive tract. And so if you were to be experiencing one of these conditions, for example, like interstitial cystitis, endometriosis, or irritable bowel syndrome, we see increased likelihood of visceral sensitivity across all three organ systems. Go ahead and move to the next slide. There's another phenomenon that we think about in pain experiences. And when the body has been in pain for a prolonged period of time, we can be at risk of what we call central sensitization, where the central nervous system starts to send more signals than we would expect it to. And in this, we're looking for a cluster of symptoms to be happening simultaneously. This idea of diffuse bodily pain, like what would be present in fibromyalgia, fatigue, insomnia, headaches, and depression and anxiety. And when those things happen at the same time, we don't necessarily think of them as separate entities, but more as a product of what the central nervous system is trying to do in response to pain. Much like the alarm system on your house starting to send off alarms with passing wind or somebody bumps the door, it's not accurately picking up on the threats in the body. You can move it to the next slide. When we experience or have something like visceral sensitivity, where we're getting more sensation out of that area of the body, we can start to, this sends signals up to our brain. We get that change in physical sensation, and it's the brain's natural and protective response to start to monitor that change in sensation. We use the term hypervigilance to describe this, the over-monitoring of the brain to that physical sensation. When we're getting an increase in sensation, this can often be associated with anxiety about what the cause of the symptom is and how that symptom is going to progress over time, especially in pain. What we've seen in GI conditions is that hypervigilance and symptom anxiety are the largest drivers in how severe a person's symptoms will be, even in organic conditions. Even when we know the cause of that pain, we still see hypervigilance to sensation and symptom anxiety as big drivers in how severe the symptoms will be and significant decreases in health-related quality of life. Go ahead and move it to the next slide. And so we think about how do we start to intervene in this cycle. I want to present here kind of how pain is related to the rest of our body's experience emotionally and physically, and then think about how on the behavioral health side we might step into the cycle. And so we start at the top with the experience of pain. And we might start to have thoughts that are how pain might affect the rest of our day, how it might affect sleep, or how doing a certain activity may or may not be likely to cause pain for us. And we could feel emotions like fear or frustration or anger or sadness that this has been an ongoing part of our experience. The pain is, in essence, a threat to both the brain and the body. And when there is a source of threat, it can kick in our body's sympathetic nervous system or fight or flight response. When our fight or flight response is activated, certain things happen in the body. Our heart rate increases, our breathing becomes more rapid and shallow. The blood flows from the hands and the feet into the main trunk of the body, and our muscles start to tense and engage. What's not important in this state is digesting your lunch. The body puts digestion on the back burner because it has more important things to handle at that time. And so we can experience not only an increase in GI symptoms, but also an increase in pain signaling throughout the body, because the areas of the brain that are responsible for pain sensation are more active when we're in that fight or flight state. And so our cycle starts all over again here. And you can go ahead and advance it to the next slide. This can also lead to impacts on our quality of life. So when we have the threat of pain, We naturally see people start to withdraw from activities that they would have enjoyed previously, whether because that activity causes pain or it could cause pain when we participate. We start to see withdrawal from social relationships as people feel like others in their life don't necessarily understand what they're going through. And the combination of these things can lead to an increase in depressive symptoms. Not only am I in pain a large amount of the time, but I'm also not participating in activities that used to bring joy to me anymore. So you can advance it. So how do we intervene on this on the behavioral medicine side? We can start up at the top of the cycle with the pain experience itself. And one of the tools that we use frequently in GI that I've also seen relevant in pelvic pain is that we can use something called gut-directed hypnotherapy, where we bring the brain and body into a very deep state of relaxation, and there give the brain suggestions on how we want it to perceive sensations in the gut or pelvis. For example, imagining a wave of medication coating that area of the body, or imagining warm or soothing sensations spreading through the nerves. And what we're doing here is really altering that communication between the nerves of that area of the body and the brain, giving the brain a different understanding of sensation. We can also work at the thought and emotional level. And our main goal there is to try to reduce the sense of threat around symptoms. We can do that by changing our thoughts or accepting our thoughts or experiences, and ultimately creating flexibility around the symptom experience. We can also work at the level of sympathetic arousal. If we didn't catch the pain, we didn't catch the response to it, we can use more crisis intervention strategies like diaphragmatic breathing or rapidly changing the body temperature, engaging in some level of physical activity that help to soothe our nervous system. And so we can work both preventively and reactively to the pain. Go ahead and advance the slide. They also do a lot of what's considered to be exposure therapy. And in this case, we're working toward gradual re-engagement in activities that we used to enjoy, because we know that that is going to increase a person's quality of life. And within this, we're really looking for flexibility around the activity. And so we may see things as very black and white. Either I stay home or I go on that vacation with my family, and there's no options in between. And what we do is help to see that there are likely many options I might be able to practice by spending 1 or 2 hours outside the home with a companion, or I could spend 1 hour outside of my own home by myself. And then I can gradually work my way up to the activity that is of value to me. Go ahead and advance it. And so where we land today, pain is a full body experience. It involves the muscles, it involves the nerves, and your brain is ultimately responsible for how it perceives and responds to that sensation. When a person experiences chronic pain, we want to help them preserve the enjoyed activities. Can we find the ways to get them back into those things that brought joy? Can we help you maintain social connection with the people in your life who will walk alongside you in the journey, and then help you manage your fear around symptoms as well to reduce the severity of those symptoms? And that's what I have for us today.
Thank you so much, all of you. Anytime I do these things, I always learn a little something as well. Dr. Simons, it was especially interesting for me to hear from you, and Dr. Wong Roberts. I think we need to work on that within our urology and urogynecology section. I don't see anything in the chat at this point. I invite any of you in the next minute or two, if you have any questions, to please enter that in the chat before we close out our meeting. You have the website there to look for more information or to call to make an appointment with any of us or one of our partners. And this presentation will be emailed to everyone who registered in the next day or two. Okay, let me see here.
I can answer this question.
Okay, thank you.
Yeah, so one of our participants asked, what is the most effective treatment for IBS? IBS is really a multifactorial disease, and it involves, in the best case scenario, having your physician, a psychologist, and a dietitian involved. There are some medications that are helpful for managing the symptoms of IBS, but we actually see gastropsych interventions to be of greatest benefit for the most part. So we use a combination of gut-directed hypnotherapy as well as cognitive behavioral therapy for IBS, really working toward these goals, just like what we talked about here, reducing visceral sensitivity, re-engaging with enjoyed activities. And alongside that, there are different dietary therapies that have been shown to be effective in managing IBS. But really working in combination with dietitian, psychologist, and physician ends up being a very effective treatment for IBS. And if there's pelvic floor dysfunction with that, bringing in a pelvic floor therapist like Cameron.
There's a question, typically how long is the wait for an appointment? That really depends on what type of specialist you are looking to see. And I would say it varies anywhere between a couple weeks to a few months, unfortunately. And certainly it may be longer if you're trying to do the self-refer because you'll be channeled to make an appointment through our normal channels. I would encourage you to talk with your primary care provider, and hopefully you have an established relationship with them. And most of us have a good relationship with PCPs that they'll often reach out to us to try to squeeze someone in or find the appropriate partner. We do understand it can be difficult to really get to the right provider, and many people with various pelvic pain conditions have seen many providers before, and it can be frustrating to feel like you're bounced around. So the short answer is it varies, but I would encourage you, if you when you get an appointment, ask to be on the waiting list. And so it may be easier to do that over a phone, because often, no matter who you're seeing, you can get bumped up pretty easily on the wait list. And, oh, you are welcome, Laura. Long question, but important. I'm going to read out loud so I can absorb this with the rest of you. I am a pelvic floor occupational therapist near Youngstown. Amazing. I'm often the first healthcare provider to treat persistent pelvic pain clients, and there's frequently a need to refer clients to a specialist, suspected endometriosis, potential IC, menopause-related pain, et cetera. Yes, it can be difficult to know who to refer these clients to next. I agree. For instance, directing clients with vulvodynia where therapy isn't fully cutting it, or receive a diagnosis of IC. Many physicians closer to me, although very good for common care, are not specialists, and I frequently refer to Cleveland Clinic. Beyond therapy, how do I know or find the specific specialist physicians to refer persistent pain clients to? Cameron, you want to take that one? And yes, round of applause for you. Oh, you're
Cameron,
muted.
you're muted.
Cameron, you're muted. Cameron, can I unmute you? I don't think so. Wait, you unmuted and remuted.
There we go.
Oh, there you are.
Better? Okay. I muted myself to make sure I wasn't making any noise. One, I love that pelvic floor OT. I did not talk about it because we don't actually have any hired within CCF, but I definitely think that's a great piece. I am more than happy to help navigate. I think pelvic floor in physical therapists or in general, or just occupational therapists too, are the unique that we do a lot of care coordination. And I'm more than happy to help. I can give you my email if you have questions for specifics for specialties regarding patients. My colleagues make fun of me. They think I'm a walking dictionary, that they'll be like, who is the West Side go-to for this condition? And I like throw out 3 names, and they're like, who's the NP that does pessary fitting on the East Side? I'm like, boom, boom, boom. I'm like, how do you remember this stuff? And it's just housed in my brain, and I talk a lot to a lot of people. So I can more than happy to throw my email into the chat, and feel free to reach out.
Okay, I don't see anything else here. Again, thank you all for your time.